Hey everyone, welcome to the Neuro Health broadcast. I'm your host, Dr. Joseph Kappas, and this is our second episode and first interview of the podcast. Today we're talking with Dr. Henry Zaremba from Apex Brain Centers as he discusses brain injury and neurofeedback. Dr. Zaremba is a board-certified chiropractic neurologist who is currently the lead clinician at Apex Brain Centers in Asheville, North Carolina. He specializes in treating various forms of brain injury, neurodegenerative conditions, and learning and behavioral disorders in a functional, immersive treatment model. As an exercise and sports science graduate and collegiate ice hockey player at UNC Chapel Hill, Dr. Zaremba's personal experience with concussions sparked a deep interest in neuroscience and set him on a career path. He graduated from Palmer, Florida as a doctor of chiropractic and achieved his diplomate status through the International Board of Chiropractic Neurology. He currently lives in Edneyville, North Carolina with his wife, daughter, and 2 dogs. This is a fantastic episode with Dr. Zaremba. He is a wealth of knowledge. So I think you are going to learn a lot and really enjoy what he has to say, especially if you've ever been interested in neurofeedback and what it can do for brain injury. So, after a quick announcement from our sponsor, Dr. Zaremba with Neurofeedback and Brain Injury. This podcast is brought to you by Delta Neuro Health, located in Columbus, Ohio, where non-invasive, personalized care is revolutionizing the way we approach complex neurological issues. With cutting-edge techniques in functional neurology, functional medicine, and chiropractic care, we're leading the way in managing conditions like concussion, dizziness, brain fog, anxiety, POTS, attention, and more. To learn more, visit our website at deltaneurohealth.com. Hey everyone, welcome back to the show. I'm your host, Dr. Joseph Kappas, and today I'm joined by Dr. Henry Zaremba as we talk about QEEG and the brain. So thanks for coming on today.
No, of course. Thank you so much for having me on the podcast. I've been a fan of your podcasting for a while, so it's good to be able to hop on with you.
I appreciate that. Yeah, it's great to have you. So just a little bit of background on yourself. Can you tell our audience a little bit about your clinical journey so far and why you're here talking to us about QEEG?
Sure. Yeah, no, absolutely. Thank you so much. I graduated from Palmer, Florida in 2017. Prior to that, I was an ice hockey player with UNC Chapel Hill. And it's kind of like a well-kept secret that a lot of these teams in the South and like the ACC and SEC actually have hockey teams. But anyways, when I was growing up playing, I've definitely been used to getting my bell rung or, taking hits, things like that. But my senior year, I had a concussion that affected me on a bit of a deeper level. I'm certain that my college lifestyle with like drinking and staying up late and partying, things like that, wasn't helping things. But what I noticed was that in addition to just like the headachehness and tiredness, issues with focus, things that I was kind of felt like it was sort of normal a day after a hockey game. I was having some pretty significant depression. And that was something where, I felt like I kind of was within fairly normal limits of depression for most of my life, but it kind of sent me into a deeper depression than I had known. I was having a lot of insomnia at the same time too. And around the same time, I was reading articles on a publication called the Players Tribune, which I know it's like directly like from the athlete's mouth across different sports. I think it's mostly published online now, but I was reading about some different players and their concussion journeys, and I learned more about functional neurology, or I learned that functional neurology exists. And then I kind of learned I could go to chiropractic school to pursue that. And I was a chiropractic patient anyways during my playing career and growing up. So getting into the functional neurology through chiropractic school just kind of felt like a good fit. After I graduated from chiropractic school, I worked at a clinic in Boulder, Colorado called Red Tail Wellness, which is a functional medicine center. I saw a lot of people with varying forms of anxiety, depression, neuroautoimmunity. We specialized mostly in like thyroid care, metabolic care. But there's certainly a link between those conditions and what we do from a neuro perspective.
Awesome.
From there, I was hired at Revive Treatment Centers. One of the guests I saw you interview recently, Dr. Brad DeBeer and
Hmm.
Dr. Hannah Wadsworth, I was able to work with them at Revive, which was a great opportunity to be part of a multidisciplinary team. We were specializing in severe traumatic brain injury, stroke, other forms of acquired brain injury, and post-concussion syndrome. And after COVID happened, most of our patients were coming from out of state. So we ended up shutting our doors. It just kind of wasn't a good combination of people having these severe brain injuries and trying to fly and travel during that time. Just wasn't conducive. So around the same time that Revive closed their doors, it's one of those things, right? One door closes, another one opens. Dr. Charlene Godet, actually, who I worked with briefly at Revive Treatment Centers and has her own center in Texas now. She put on my radar that Dr. Michael Trayford, who I currently work for in Asheville at Apex Brain Centers, was looking for someone to join his team. And it's been a great fit. He's been an awesome mentor to me. And that's, I guess, brings things full circle to why we're here talking about QEEG and functional neurology today. QEEG was something I knew about when I started working with him, but it
Hmm.
wasn't something I would say I had a lot of clinical expertise. But Dr. Michael Trayford has been a leader, especially in the functional neurology community, in terms of integration of QEEG into that sort of practice model.
Hmm.
He's currently a board member on the ISNR, the International Society for Neuroregulatory Research. I think he left today a little early. He's going down to Charleston for a board meeting with them. So he's one of the few chiropractic neurologists, one of our few of our tribe that's kind of representing among, these PhD psychologists and, sort of more of that more academic world and psychiatrists. And yeah, so
Yeah.
that's why we're talking about QEG.
That's awesome. I love your story. You sounds like you've had not only personal experience, but now professional experience treating concussion. And I'm so glad that you were able to find a functional neurologist that's helped you out. And you've worked with some of the best in the industry, in the field. So you are obviously perfect and well equipped to talk to our audience today. And Dr. Trayford, I don't think I've ever had him on, but I know he does really cool things with the Erconia laser and QEEG. Is that right? And maybe we'll
Yeah,
get into that a little bit today as well.
I'd
Um,
love to.
awesome. But Dr. Zaremba, for our audience members who are like, what the heck is he talking about? QEEG, it's just some word letter soup or whatever. What exactly is that and how do we apply that?
Yeah, no, absolutely. And that's, I think, the best place to start. So with QEEG, I think the best place to understand is kind of where we've come from. And it comes from the same technology as EEG, which is electroencephalogram or electroencephalography, where we're measuring the output of electricity that's coming across the skull. Now, certainly, we're measuring like those neuronal firings that are happening across like the meninges and the scalp and the skull and the hair and all of that. But by measuring that and comparing it to different references and, kind of having the proper recording equipment, you can look for things like epilepsy, stroke, traumatic brain injury, on more of the large physical lesion type of level. Um, Even for different forms of like encephalitis related to things like an infection or other surgical damage and injuries, and EEG has often been something that's been used in the past to understand is there brain function under these electrodes that we're trying to measure. Now QEEG is a relatively new invention since about 30 years ago, where what QEEG does is it takes the electrical output over different parts of the brain, and it then compares that to databases that have been compiled of the EEG output across different individuals.
Mhm.
So with a QEEG, we're looking at more measuring the specific level of electrical output, whereas with an EEG, we're sort of looking at it from more of a general sort of perspective. So QEEG is a much more statistical, analytical form of EEG that then lends itself well to being compared to other forms of diagnostics and then even being used as the basis for treatment paradigms.
Mhm. And you mentioned the initial use case for EEG was things like epilepsy, stroke, right? So that's not exactly what we're looking at when we use QEEG. Some of that can be picked up, right? But that's
Right.
not exactly the goal of QEEG. So I know a lot of people that I've worked with sometimes like have that question or sometimes get that confused. So,
Yeah, no, definitely. And even just myself kind of like starting into this world, I remember thinking like, okay, this is a hemiplegic stroke. They had a stroke on the left middle cerebral artery. They can't move the right side of their body and they have aphasia. It's like the textbook kind of walking in. I'm imagining like, okay, like the brain waves are going to like, there's going to be just a line right down the middle and the brain waves are going to be very different over here than they are over here. And that just tends to not be the case. And there's a lot of reasons for that. But you're exactly right, where it's very much a more deep dive into the function of these cells than just kind of ascertaining, are they viable or not.
mhm. And I
Right.
think something also in my experience having worked with QEG and then looking for practitioner referrals for patients, what are some things that you need to look out for when you're researching a provider that provides neurofeedback or QEEG care?
Sure. No, that's definitely a good question because I know that there's probably people listening out there that kind of want to know how to get started.
Mhm.
And One of the best things to look for is board certifications. Both Dr. Trayford has his BCIA certification through the International Neurofeedback Society. I'm working towards that myself. So having those certifications is the type of thing where obviously you can have the education without that, but it can be helpful to just kind of let the patient feel more at ease in terms of there's definitely been some education here. This isn't someone that just kind of decided to do this is someone that for a long time has been studying this. Other things that I think can be really helpful is even looking for patient testimonials and reviews. Now obviously you can see that reviews somewhat are like solicited nowadays, or people are like rewarded for giving good reviews, so kind of take that with a grain of salt. But especially if you see one that they really wrote about that their experience, that can really help. But those, I think the board certifications is one of the best things, as well as just kind of the experience. I
Mhm.
mean, brain-based care is what we do all day every day. I love chiropractic. I think it's fantastic. It's helped me a lot in my life, and we use it with our brain-based patients here. But we don't take patients for pain. We don't take low back pain. We don't take headaches as our. When I've got a great network of chiropractors here in the Western North Carolina community that I can refer to on that. But I think it's about that specialization. It's sort of Dr. Trayford's told me a bunch of times that you can either be a jack of all trades and master of none sort of thing. So being looking for that practitioner where that's what they do is they see brain-based care and especially when it comes to something like QEEG, where some of the treatment forms is like neurofeedback or other forms of biofeedback, where we're trying to alter someone's brainwave function. We want to make sure it's someone that knows what they're doing,
Right.
not just someone who downloaded a software that says it works and X,
Mhm.
Y, and Z.
Right, right, exactly. So that's good that those are some great things that people can look for because there's so many things out there on Google that you can find. So that's a good guidepost there. So we've defined QEEG. Patient comes to your office, they acquire QEEG testing brain map. What can they expect to see then on that brain map? How do you then explain the results to them, and what are you looking for?
Absolutely. So there's a lot of different levels to the QEEG analysis. So for our reports, We're doing eyes closed and eyes open testing for people for about 8 to 10 minutes each. We like to get a nice long recording so that there's a good representation of how this brain is functioning. And Eyes open, eyes closed, each of those is going to generate about 4 reports. And some of those reports are a couple of pages. Some of those reports are about 70 pages. So, in terms of the like depth of magnitude and things to look for, I mean, you can like really go down rabbit holes. But to start off, and especially from like the patient perspective, we look at what are called summary maps, which look at absolute and relative distributions of different frequency bands. So in QEEG, the frequency bands, or the different types of, they're called brain waves that we can measure, are delta brain waves, which fall between 1 and 3 hertz. We have theta brain waves, which are between 4 and 8 or 9 hertz, 4 and 7 hertz. Some of these definitions vary depending on who you read. Alpha brain waves generally are 8 to 12 hertz. Beta brain waves, and then high beta brain waves, and gamma brain waves as well. So, like I said, it's just, you just scratch the surface to these things, and the depth you can go to is just absolutely massive. But looking at the summary maps, right, I just start usually on a very basic level, where we'll usually, one of the most common findings that we'll see is increased slow activity. So for something like post-concussion syndrome, or someone with a history of head trauma, one of the clinical hallmarks that we see fairly commonly in our office is increased theta brain waves. And sometimes that comes with increased delta increased delta brain waves as well. And that sort of slowness, I usually explain to patients like driving with your foot on the brakes, things like that. Or with our faster brain waves like beta and high beta, if we see those in excess in areas like the frontal lobe or the temporal lobe, a lot of times that'll correlate very much with anxiety. So I try to take experience or a symptom that the patient has told me about, one of their main symptoms, not just something they like briefly told me about as a matter of fact additive thing, but what are some of their main reasons for seeking care with you. I want to try to help them understand how what we're looking at on these summary maps corresponds with what they're feeling. And then from there, usually I try to help them understand that this can be changed, right? Brainwave states are dynamic, and people can affect their own brain, right? This whole functional neurology thing, right, is based on neuroplasticity and the ability of these cells to not only modulate their own activity, but grow and change, form new connections, form new neurons in the brain. So when we're explaining things, we typically are looking at the main symptoms. We're talking about how the brain waves pertain to that. And then we'll usually talk about, well, if we can get your brain waves to look like this, then this might happen, right? If we can shift your excessive beta output in the frontal lobe from greater than 4 or 5 standard deviations above the mean, meaning way, way above average, to closer to 1, 2, even for some people, if we're going from 5 to 3 standard deviations above the mean, we can see major symptomatic improvements with that. So the summary maps are a great place to start. In our office, we're also using a technology called S-Loretta imaging, which stands for low resolution tomographic analysis. And essentially, this is another level of software on top of QEEG analysis where we can actually recreate a 3-dimensional sort of understanding of the electrical output of the brain. So we can start to even localize brainwave activity in areas like the basal ganglia and deep brain structures, which especially in our clinic, dealing with a lot of people with learning and behavioral disorders, issues with mental health, brain injuries, where oftentimes finding the S-Loretta imaging will show us things that we initially didn't see on the QEEG. So yeah, the levels just keep coming, and depending on what the findings are, I'm likely going to use the S-Loretta imaging as well to kind of help that make sense in the patient's mind from 2 different perspectives, as opposed to just saying it's this, so that way they understand it's more of a complex network of state changes in your brain, not just you have delta brainwaves, right? We all have delta brainwaves.
Right.
It's just your brain, your neurons are almost stuck in this delta brainwave state, and how can we kind of shift them out of that. So usually I'm talking to them about what we're seeing on the QEEG as a way of understanding why they feel how they feel, and then what do we want to do about it to get you feeling better.
Right. And I think that's an important thing to highlight is, yes, we all have delta brainwaves active, right? We
Right.
all have theta, alpha, beta, gamma, high beta active at all times. But what I typically tell people, or what I tell people is, these brain waves are more or less active depending on the scenario we're in, right? Like if we're sleeping, we're probably going to have a little bit more delta theta activity, right? If we're really engaged in something, we're probably going to have a little bit more high beta activity. If we're feeling really zen and calm, somewhere in the middle, we're probably going to have more alpha wave activity, generally speaking. So if
Right.
you can test somebody, would you say 8 minutes, eyes open, eyes closed?
Yep.
So
Generally.
there's
Yeah.
there's a standard amount that those brainwaves should all be active in each person, relatively speaking. So if somebody has too much of that delta wave activity, or even too little of that delta wave activity, then you can, like you said, correlate that to the symptoms that they're coming in with. Right. And I always told patients, I have two criteria for neurofeedback care. And that is, A, do we find anything significant on the brain map? And B, does it correlate with the symptoms you want to actively resolve, right? Because
Right.
someone
Yeah.
could have
Yeah.
anxiety or depression and have a completely clean brain map, right? Or they
Yeah.
could have a terrible brain map and it not even correlate, because there's a lot
Right.
of factors that can contribute to somebody's symptomatology. So you really have to, I've found you need to have that kind of marriage of those two criteria. I don't know if you.
Yeah. No, absolutely. I think that's a good way of looking at it. I haven't kind of put it in those words before. But no, absolutely. If a patient comes to us and their main goal is to reduce their anxiety, I don't necessarily need to talk to them too much about things like alpha peak frequency, which has more to do with like cognitive preparedness and like intellect and like focus and attention. And while certainly there's some correlation there, it's not as directly applicable as if we're seeing something like that increased in frontal beta or high beta.
Mhm.
So yeah, no, absolutely right. I think you hit the nail right on the head with that.
and and speaking of so anxiety, mentioned that a couple times.
Sure.
What are some of the conditions that neurofeedback seems to help out really well with?
Yeah. So in terms of the conditions I've seen it help the most with, um, so just kind of disclaimer, most of our patients are doing more immersive forms of care where we have them in the office for 4 to 5 hours a day, and they're doing cold laser, hyperbaric, they're doing eye movement training, vibration training, interactive metronome, and then neurofeedback for some patients. That's part of it. So, but for a lot of what we see are patients that are in hypervigilant states. That's why I mentioned anxiety a couple of times. And it crosses a number of different conditions, whether it's, someone may have had a stroke and they're anxious because their balance is off. So they're kicking these fight or flight responses every time they take a step because their vestibular nuclei are detecting these aberrant movements. Post concussion syndrome, people that have light and sound sensitivity where normal amount or what would be average amounts of sensory input for most of us on a day-to-day basis drive someone into a fight or flight state, right, where they sort of can't handle it. So that sort of hypervigilance and that imbalance and the balancement and the fight or flight symptom seems to be something where I learned early on in my career, if someone is stuck in fight or flight, their neuroplasticity is in the tank. So it's going to be more difficult for them to respond to all the other care that we're trying to administer. So one of the things that I've seen neurofeedback can be very valuable for is for helping people to be able to attenuate their own fight or flight responses. Oftentimes, this is called auto-regulation or self-regulation, where people are able to feel okay. A way of kind of explaining that too, one of the communities of patients that we tend to work with are patients with substance use disorder and addiction. There's a few different being in the mountains and kind of nicely situated with like outdoors activities and things like that Asheville is actually kind of a hotbed for recovery centers in the Southeast, especially. So we'll see people from all over the country that are coming to, some sort of recovery center here in town, and they'll come in for some functional neurological care on top of that. And these people can't auto-regulate. I use substance use disorder to explain that idea of self-regulation to people all the time, because it's kind of the most blatant example of that. You can't regulate yourself unless you have alcohol in your system. That's kind of how you regulate yourself, is you drink or you smoke or whatever drug of choice. So if we can use neurofeedback as a tool to enhance someone's ability to self-regulate, that really opens the door for a lot of our other therapies, whether it's eye training, whether it's physical therapies and sensory motor training, whether it's interactive metronome training. It kind of opens the door for these other therapies to be more effective. Obsessive compulsive disorder is another one that we see to a really high degree, or even people with, other similar types of diseases, where the issue is this impulsiveness, this inability of the filters in the brain to filter out the unwanted movements, and also the intrusive thoughts is another thing that we're seeing get more attention, I guess you could say, sort of like in the atmosphere of like health based social media and things like that, and conversations that are happening around it. Because OCD was always thought of as, well, you just wash your hand a lot, you like to be your hands a lot, you like to be really clean. But oftentimes these same filters that are filtering out these unwanted behaviors and actions aren't catching intrusive thoughts, negative thoughts, dark thoughts, unhappy thoughts too. So I know you asked me about conditions. I rattled off kind of a couple there, but it tends to be, from my perspective of where I've seen the neurofeedback be, at least in the scenario of our clinic, I've seen it do wonders for people that have that sort of hypervigilance, that sort of anxiety that will get in the way of our ability to engage in other forms of care. So it's sort of like the gift that keeps on giving, because it's helping them get better on its own, and it's also sort of opening up their accessibility to more learning and growth.
Right. Um, can you offer a picture on what the training then looks like? So we've kind of talked about the conditions that can be managed, as well as what maybe an intake will look like and how to interpret that data. So then how do we actually get the improvement?
Right. Yeah, absolutely. And neurofeedback is sort of one of the most directly, we're directly trying to train brain waves, and that's one of the tools that we've been talking about a little bit, where essentially the way that we're doing it in our clinic, and it's sort of a big umbrella of different forms and technologies out there of treatment, is we're doing a lot of Z-score training. Two of the main kind of umbrellas of neurofeedback training are power-based training, where we're trying to, for example, decrease delta brainwaves and increase alpha brainwaves. So anytime that we are moving in that direction where delta is going down and alpha is going up, no matter how high delta eventually gets or low it eventually gets, as long as it's trending in that direction, the brain is given a rewarding stimulus, whether it's increased sounds and lights, changes to the tone that we're hearing. We can use games and other interfaces, but for the most part, we're doing it pretty simply, just changing brightness of the screen with the dimmer and changing the sounds that they're hearing as well. And I generally explain it to patients like, the computer is reading your brainwave signals and it's trying to train your brainwave pattern into a more normative pattern or a healthier brainwave pattern. You don't need to consciously try to keep the screen bright or change the sounds that you're hearing. I generally am instructing patients to stay focused on their breathing, try to stay nice and calm. It's naturally the mind's going to wander a little bit. You'll be like, oh, my butt itches, I'm kind of hungry, X, Y, and Z. And then eventually you pull your mind back to that breath work, that kind of recentering. And each time you do that, you're flexing that mindfulness muscle. So patients will, get set up with, whether it's a cap or leads, where, setting up our montage of ascertaining that brainwave information. The patient is watching a screen that's changing based on their brain waves. And eventually, the hope is that the brain will understand and recognize that the timing of the stimulus and the reward correlates with the brainwave the brainwave patterns. And traditionally, with neurofeedback research and how it's practiced out there, people are being recommended to do, 30, 60 sessions of neurofeedback, a couple of times a week for 15, 20 minutes, however long it lasts. We're seeing cool results with QEEG changes in 5 to 10 days with people. I think because we're combining the neurofeedback with more of the immersive care. And the Z-score training, the other form of training that that kind of power and Z-score, the other form, Z-score training is training more to statistical norms across different metrics. So we're training alpha, delta, theta, beta, and gamma all at the same time. And not only are we training them to get into certain zones in terms of their amplitude, we're also training asymmetry in terms of, are your alpha brainwaves the same on the left as they are on the right? Coherence, meaning the timing of them. Are they kind of timing each other? Is the activation of these different areas relating to itself appropriately? So with the Z-score training, it's a little more in depth, but it tends to be less metabolically taxing because it's not just kind of pushing these numbers in a certain direction. It's kind of honing them towards the middle, if that makes sense. And we found the Z-score training really complements the immersive care to a bit of a higher degree than the power-based training does. But we do both in our office.
Excellent. So one thing, as you were talking about the training, it reminded me of a question I often get from patients before they start neurofeedback training. And maybe it's someone who's really creative, or maybe it's someone who's really, logical. And that's what makes them them, right? That's what creates their personality.
Right.
That's maybe what's helped them to thrive as individuals, right? Their creativity or their linear thought processes. So something that people are often hesitant about is starting care thinking that it may take away that edge that maybe they have at the gain of maybe lower symptoms, but the cost of losing that. What would you say to that patient?
Yeah, no, I mean that's definitely something where I can understand where that concern is coming from. But creativity and linear thinking don't have to be mutually exclusive processes. In fact, they can actually enhance each other when done properly. And I think that sort of goes back to almost like the idea of like savantism, and people having that sort of sense of, well, we only use 10% of our brains, right? Which, that study didn't really say that. That's just kind of the quote that came out of it. But that's sort of the sense of like, oh, well, I'm just really good at this. And that kind of excuses my deficit in this area of personal growth. And sure, certain people have strengths and weaknesses. But if you're seeking care with me, I want to assure you that we can help you see improvements without it being at the detriment of your strengths. We'll explain that to patients all the time, where we're gonna, in this meeting, where we're gonna go over your diagnostics, we're gonna go over your brainwave patterns, your VOG, whatever testing we've done. We're going to talk a lot about your weaknesses, but your brain also has a lot of strengths, and we can use our strengths to enhance our weaknesses. For example, with a stroke patient who has hemiplegia, because it just kind of lends itself well, you can work on the good side to do complex coordinated movements, sensory motor integration, other forms of physical training that'll have effects on the affected side as well. So yeah, those two things, they're not mutually exclusive. And generally, we're checking in on patients frequently when they're coming in for visits too, just to make sure things seem like they're shifting in the right direction.
Mm-hmm. Makes sense. As a patient enters treatment with neurofeedback, what is the expected recovery time? Like
Mhm.
how invested should a patient expect to be?
Sure. So I would say, for example, with the Z score training, we're seeing that most of our patients are able to do a 15-minute session, we get the cap off them, get them out of the room, and we'll, get right on the vibration plate and start doing some cognitive exercises. So it really just depends. Most of the neurofeedback training that's out there is power-based training because it's just been around a little longer, a little more well established. There are those PhD types and the research people that, haven't fully accepted Z-score training yet, or, X, Y, and Z. There's those people that'll just kind of die on certain hills, so to speak. But uh, for most people, especially if you're doing power-based training, I wouldn't schedule like, recording a podcast right after you're, doing neurofeedback, especially if you're doing it for the first time, or you're changing protocols, or, there's some sort of shift happening. But for most people, especially if you're doing repetitive sessions, you can get a good understanding of how you're going to feel afterwards. And that's just super individual. I've seen people where they're just like tanked for the rest of the day, and there's a lot of things that go into that. And, like I said, some people, we just, get them off and we go right back to work.
And you mentioned kind of combining the other neuro rehab type exercises that you do even with those neurofeedback patients. So can you talk to what patient progress is like when you pair them? Because I think that's something that definitely sets clinics like ours apart, is that we don't just offer neurofeedback typically. Typically we also have other things that kind of work synergistically with the neurofeedback. So what have you seen with that combo?
Yeah, no, absolutely. Really well put. It's um, just kind of another note on that idea of kind of the amalgamation of multiple therapies working synergistically. A lot of times I'll have patients ask, like, oh, well, like, what's going to help with this? And is that going to help with this specifically? And generally the answer is yes. And I kind of explain it as we're baking a cake, and the cake isn't one of the ingredients, it's the way the ingredients are combined, the conditions under which they're combined. And maybe it's a gluten-free cake since we're talking to the health community,
Of
but
course.
yeah, right. Yeah, so being able to look at things like specific applications of neurofeedback coupled with other functional neurological interventions is something that's just blown my mind since I've been learning from Dr. Trayford. He's been an awesome mentor to me in that regard.
Mm-hmm.
One of the coolest things is I was recently at a continuing education seminar that was hosted by Arconia here locally. And Dr. Trayford spoke about, presented on patients. I think the title of the talk was "Lasers and Brainwaves," and was talking about how lasers and low-level laser therapy, photobiomodulation, there's a lot of ways that we can measure its effects on cells, and we can look at patient outcomes. And QEEG is just one of those areas where there's not a robust amount of research in terms of like exterior literature and things that we're reading. But in terms of just in-house looking at some of the results that we see, yeah, laser absolutely affects QEEG. And part of the talk, he actually, we work with Brainmaster is the company that we use for our neurofeedback and QEEG equipment. We had a rep there who was doing QEEGs on the participants of the seminar out in the vendor hall. And one particular person with a history of concussions, anxiety, some other issues, kind of volunteered to be sort of a test subject so that we could show something called the live Loretta projector, where, like I was talking about, that idea of projecting the three-dimensional brain from a QEEG perspective using that S-Loretta technology. So we had this, volunteer up in front of the room wearing a cap. We were projecting her brain waves, her S-Loretta imaging, basically this three-dimensional model of her brain was
Mm-hmm.
presenting on the screen with, red lights showing where there was too much of a certain brainwave, blue if it was too little, and sort of all the colors of the rainbow in between. One of the things, I believe it was excessive slow activity. So I think we saw some high theta with this patient. And Dr. Trayford took one of the Arconia lasers in real time. We were all looking at her brainwave on the screen, and he started lasering over, I think, her sensory motor strip or something like that, one area of the brain where it was particularly concentrated.
Mm-hmm.
And we could watch in real time on the live Loretta projector as those brain waves not only attenuated, but actually like swung kind of far in the other direction at a certain point. So then he's like took it away, like, oh, that's a little too much of that. But um, that's where that was one of those instances where we're seeing that, like you mentioned before, we're looking at a snapshot of, or a sampling of these dynamic states. And you're not just one or two of these brain waves, but by looking at them sort of cohesively. For example, we see a lot of people with things like movement issues, whether it's related to a brain injury or a stroke, essential tremors, cerebral palsy, things along those lines. And for a lot of those patients, they're severely deficient in a range called sensory motor rhythm, which is also called low beta for a lot of people. So alpha brain waves go from generally about 8 to 12, some people say 13 hertz. And the sensory motor rhythm, or SMR, is primarily in that 12 to 15 hertz range. And that's what is that brainwave is correlated with. I always explain it to patients as relaxed control of the muscles. You're ready to move. You could move if you want to. You're sort of poised and waiting, but you're not actively flexing. You're not actively moving, problem solving, etc. And whether this patient is suffering from dystonia, tremoring, dysmetria, dysdiadochokinesia, whatever sort of aberrancy to their movement or muscle tone we might be seeing, we can do neurologic or neurofeedback, sensory motor rhythm training on the motor cortex or over the premotor area, um, to be able to basically help enhance the ability of this brain to generate those brain waves, which then helps to enhance our other physical therapies like doing gait training or whole body vibration, balance training, things like that. And so we try to time them together to where we're using the principles of neuropriming, where we're sort of activating these areas from multiple different avenues, both active and passive means, bottom up and top down approaches. And some really cool things. We have a patient in the office today, actually. So this week, it's one of our regular patients. He's back for his 7th visit, I believe. But he was a AVM patient where he suffered a massive stroke secondary to a previously unknown and large AVM. He had one of the largest crania. It was like they had to call in a team of national surgeons to come to Charlotte, and they did the craniotomy hole. There's a picture of him like holding the skull model that they made for him, showing the actual pattern of the craniotomy that they were going to do, cutting away of his skull to fix that. And he was in a coma for a period of time. They weren't sure if he was going to make it. And the first couple of times I was working with him, really severe pain, severe myoclonus, gait dystaxia, transfers, sitting up, standing, anytime he was just moving around anywhere in the clinic. It was, all hands on deck to make sure, right? Safety first. If we're trying to help this patient and they fall in our clinic, that doesn't help anybody. But it's amazing to think, it's a year and 3 months ago that he initially presented to us, after sort of getting into a level where he was able to be receptive to therapies. And it's cool. One of his things is he always says that like batters in baseball have a walk-up song. So he has a walk-up song when he comes in every morning, and he kind of takes the song, like today it was Don't Stop Believin' by Journey, and he like changes the words like don't stop my therapies or whatever it was. Perfect. But and that in and of itself, right, represents massive improvement for this person that surgically essentially had a huge portion of their brain resected. He would, in the early forms or in the early days of us caring for him, he would literally just fall asleep having a conversation with someone because his brain was that energetically and alertness and consciousness just unstable. So the fact that he's at this point, he's walking around, he's singing, he'll like pick up the cane to like mess with me a little bit, like, oh look, I'm walking without my cane now. And it's cool too, because we even get to see that he takes it upon himself to sort of connect with other patients that are in the office and sort of say, keep up the good fight and be a source of encouragement. That's kind of, that's one of the things that I think he's taken from this is his role in helping others with what he's gone through. But anyways, fantastic, man. Yeah. he's someone where we've seen the sensory motor rhythm training with the neurofeedback. I think has definitely been a big part of not just him being able to move better, walk better, talk better, think better, but also his ability to get through our immersive protocol, um, and just have that resiliency, that metabolic capacity of the brain. I think a lot of what we were training initially is just the brain's ability to be alert and focused for that long. And for a patient that was that unstable to now be where he is now, he's doing longer sessions of neurofeedback. So it's really cool to see just kind of how that neurofeedback was such an additive part of his healing journey, and he's a great success case.
Yeah, I mean, it sounds like he's been through so much, but it's great to hear that you guys are helping him and he's got such a good attitude about it. And I love that. Don't stop my therapy.
Yeah, yeah, no,
Yeah.
he's sneaky good at it. He's clever. He's like the Weird Al of brain based parody. But
There's a niche for you.
yeah, yeah, exactly right. Yeah, I was telling him we should just start a podcast, but the I feel like I had a point and I forgot what it was, but yeah, let's
Well,
just keep
well,
going.
I'm glad. So we were able to circle back to the laser and the neurofeedback because I was actually in an Ohio-based conference a couple weeks ago, and Urconia was there as well. And
Mhm,
I was talking with the rep, and she's like, "Oh, do you know Dr. Michael Trayford?" And I'm like, "Yeah, I know. I follow his stuff. I definitely know about him. I don't think we've ever met though." Um, but she's like, check out this video. And she showed me the video that you just described. And I was like, oh my gosh, that's so cool. Like everybody just immediately probably got it at that point in
mhm.
time. So yeah, that's so cool. That
Yeah, and even like we talked earlier about the idea of how do you explain that to a patient, it's
mhm,
like how do you explain any sense of neurology to a patient, right? Like Dr. Don Dishman, who's with Parker University now, is instrumental in me kind of getting into neurology and just kind of my career in a lot of ways. But he was my professor at Palmer, Florida. And I remember him mentioning the idea of, um, sorry, I'm having some brain farts. What were we just talking about?
the
The,
Arconia and the
yes.
in that
Uh,
video.
yeah. Okay. So, uh, what was he talking about? Anyways, that point is lost. But for a lot of people, we have to help them understand these complex. Oh, okay, I got it now. So
Mhm.
sorry.
That's okay. We can edit it. Yeah, it's fine.
um, so Dr. Dishman, I remember one time he was talking about, he was just kind of, going off on a tangent, and he was talking about the idea of informed consent,
Mhm,
right? And it's almost like it's kind of an oxymoron because it's like we're the ones that inform the practitioners and the patient is the one that has to consent. But we've spent, a great deal of our lives and attention and focus and finances to be able to get the education we have and actually get informed right on these
mhm,
things, and the patient's the one that has to consent. So how do you get that across to them? And I think people just love pictures, like they're visual learners.
mhm,
People love, my patients love QEEGs for the post treatment success. I'll have them printed out, I'll be like, put it up on your refrigerator like your report card. You'll see the glaring red on one side and it's more balanced on the other side.
mhm.
But a QEEG, and especially with the Loretta projector being able to show them this three-dimensional brain with their specific activity on it, it just seems to click more for patients as opposed to something where I'm explaining how a saccade has everything to do with your ability to move your arm on one side of the
Mhm.
body. But there still is just some processing and understanding that has to happen there.
Yeah.
Whereas with the QEEG, it's a little more, there, that is the problem right there, and we're looking at it.
Yeah, a lot of things we talk about with patients are very abstract. So if
Right.
you can say like, this is your brain and this is literally changing before our eyes
Right.
because of this intervention, because it's like, oh yeah, you're putting a light on my head. Like, sure, that great. I guess that helps, but
Yeah.
maybe if you say so, and then that kind of thing. But if you can actually see the real time changes like that, that's so profound. Yeah.
Right.
That's
And
great.
then even just from a results perspective, when patients
Hmm.
see that, they're going to manifest that, as opposed to, I'll see patients where their diagnostics look better, but they're just, subjectively like, I don't feel any better, and
Hmm.
so it's that whole idea of being able to show them something that's tangible and they can understand, is good for them to understand, like get that in their head, in a real way and comprehend it. But it's also a cool way to like even just enhance their results, right? With
Hmm.
intentionality and what some people call the placebo effect.
Yeah. Something else that I often get asked, if a patient is considering neurofeedback therapy is, is it going to stick?
Hmm.
Is this something I'm going to have to do forever in some capacity? What have you seen? What do you tell patients who ask that question?
Sure. Yeah. No, that's a really good one, and an important one with neurofeedback. And I think some of that goes back to, like, you were asking me about like what to look for in a practitioner. That's a good question to ask someone you're thinking about working with. Our brain is always, I always tell patients, our brain is always rewiring itself. A healthy brain is always rewiring itself to what it's exposed to on a 24-hour basis. So with neurofeedback, sure, we might, kind of be doing it intensively, get these changes. Is it going to just go back all of the sudden? Typically not, from what we're seeing. Like I said, we're doing more of the immersive kind of model of care, where we're doing a lot of sensory motor rehabilitation, eye movement training, sensory reprocessing, hand-eye coordination exercises. Um, when we're re-educating systems that feed the brain information, um, everything that we do, right? Walking, talking, looking at things, thinking, planning, it all reinforces those changes that we've made. So it's sort of like with weightlifting, right? If you're like, you get yourself to a point where you can bench press 500 pounds or a ton of weight, if you stop bench pressing for a month, you're not going to lose all of that strength, but you're probably not going to go back and bench something extreme like 500 pounds.
Mhm.
So some of it depends on what your expectation from the performance of your brain is. What are you expecting your brain to be able to do for you? um, but also, for a lot of people, it has to do with, we're also trying to facilitate lifestyle habits that are conducive to whatever changes they're trying to make. If someone can do all the neurofeedback in the world, but if they leave the neurofeedback center and they go get McDonald's, or they go, immediately do a bunch of shots and, drink some beers or something like on the way home, and they're a chronic alcoholic, even if we do see positive changes on some of the post baseline testing, I doubt that it's going to last, because, excuse me, rewiring on a 24-hour basis, what they're putting into their body, what they're providing their brain with in terms of stimulus, is not healthy, right? It's not conducive to that change. So the brain is going to kind of rewire itself to be reflective of that.
Mhm.
And that's where we'll even talk to people about the idea of like setting, you know what I mean? But who would, like, your setting, everyone kind of understands that, right? Like if you're out in nature, or you're at like your happy place, for some people, going into a church or a holy place kind of changes your brainwave patterns, right? It changes how you feel, changes your just sort of default mode network, like kind of how your brain is processing. And we'll oftentimes encourage patients, whether it's depression or anxiety, learning and behavioral changes, to look at enriching their environment. Even if I know people are limited, it's not like they can just up and move, but maybe, paint a wall in your house a different color, move the furniture around, get outside, get exposed to the sun, put yourself in social situations so you have a peer group, you can get some serotonin signaling in your brain. So I think that looking at neurofeedback, it's a massively powerful tool, and there are a lot of people that it helps on its own, even without all those changes. But generally, I'm trying to encourage people to say, you're in control of that. This is something that this is a team sort of partnership, where I definitely have my role to play in terms of being the best practitioner I can for you. You have a role to play as well in terms of, as a patient, it's not really for me, it's for you. Like, are you
Mhm.
going to do these exercises at home? Are you going to change your diet? Are you going to engage in mindfulness practices and prioritize your sleep? And just kind of, even just on a basic level, those things can dramatically change someone's life. And neurofeedback just tends to help get them there faster and help them be more kind of on track with the plan, whereas some people might be able to hold that up for a couple of days and kind of veer off of it and, go back to old habits. So the idea of how long does it last, how long does anything truly last if we're not fostering it and cultivating it? So that's some of it, but a lot of
Yeah.
it does kind of maintain itself.
Yeah, exactly. Well said. Could not have said that better myself. So agree. Um, well, we have talked about a lot of great things concerning neurofeedback. We've gone over a lot of information, and I think we've made it digestible where those listening are really going to have a good grasp on it if they didn't have any idea what neurofeedback was before coming into it. But before we wrap up, is there anything that you think we missed or left out that folks should know about concerning this topic?
Sure. I think one last note or one last thing that I thought would be cool to just kind of share and talk about is the
Yeah.
idea of entrainment. And one of the devices of, I think a lot of people have seen like on their feeds, especially in the circle of people that are listening to this podcast, is like brain tap, which is a form of audio visual entrainment. And basically what we're doing there is we're taking lights and we're taking sounds. We use a different device than brain tap called the David Delight Pro. But using specific frequencies of lights and sound, we can actually get the brain to mimic certain frequencies. So, right, we were talking about sensory motor rhythm between 12 and 15 hertz as having sort of relaxed control of the body for people with movement disorders, especially. Um, if we want to reinforce that brainwave pattern, not only can we do neurofeedback to help the brain sort of have a higher level or higher amplitude of those brainwaves, but we can do audiovisual entrainment, either with the eyes open or eyes closed, where we have special eye sets with blinking lights on them that'll blink between 12 and 15 hertz. We'll listen to sound that's between 12 and 15 hertz, and then we're actually doing cranial electric stim at the same time too, either at the same frequency or at a slightly higher frequency. But I think it's just amazing to kind of use that as a way of understanding that in modern medicine, we're just literally using like frequencies to heal people. It's the type of thing where, it's like almost going back to like the magnetism and like some of the, more like quackery type of things from the turn of the century. But like that idea of like resonance theory and different frequencies to change the way that cells are, cells are functioning, whether it's light frequency, sound frequency, even smell. Smell is a frequency of vibration of different molecules. QEEG is just a way of understanding a patient's frequency, and then we look at all these frequency adjusters that we have to try to kind of get the radio station to give us a little bit better of a signal. So with audiovisual entrainment, with QEEG, neurofeedback, I mean, growing up a Star Wars nerd, the idea that I
Oh,
get to go
geez.
into work every day and
Yeah.
use something that's called a laser on people and affect their brain. I mean, I'm
Mhm.
nerding out over that for sure.
Yeah. Oh, you don't get me started. I love it. So,
Yeah, that's the next podcast.
mhm. It's like I feel like I'm using the force every day, Just,
Yeah.
or like
Yeah.
or yeah, stuff like that. But anyway, I digress. That's for another episode.
Right. Yeah. Yeah. Exactly. Midichlorians and functional neurology.
Right, right. You don't know what that means? Yeah, you need to
Yeah.
watch more
If
Star
you
Wars.
if you do know what that means, you're in the circle.
Yeah, that's right. Well, Dr. Zaremba, this has been fantastic so far. I've loved this episode. Um, how can people reach out to you or find out more about you and the clinic you're in?
Sure. So apexbraincenters.com, plural. We only have the one location in Asheville, North Carolina right now. Hopefully that'll change in the future as we expand. But apexbraincenters.com, we've got a lot of great information about some of the different therapies we engage with and services we provide. A lot of more information on QEEG, neurofeedback, neuroplasticity. We also have a blog that's fairly active with myself and Dr. Trayford contributing articles pretty regularly too, trying to talk about topics that we're seeing people want to learn about. So that's a great place to go. And also our Instagram is the same thing. It's just at Apex Brain Centers. And we also push a lot of our Instagram posts out to Facebook, but Instagram just tends to be where our audience lives. But I'm probably going to make a post on Instagram after we're done with this recording.
Yeah, perfect. Yeah, same probably.
Awesome.
Well, fantastic clinic out there in Asheville, North Carolina. You guys are doing great work. So it was a pleasure to have you on. Looking forward to the next one.
Perfect. Yeah, likewise. Wishing all the best with your new venture, kind of setting off on
Yes.
your own, and I'm sure it's going to be great.
Yes, I appreciate it. Well,
Excellent.
from your host, Dr. Joe, have it. I don't know how I want to end these podcasts yet, so
You'll come up with the sign
yeah,
off.
yeah, I'll come up with that later. But man, I had